Indiana is fighting an epidemic. Close to 70% of people with psychological problems smoke, and they smoke a lot. Without help, people will continue to suffer and die prematurely. Indiana must improve tobacco treatments, specifically for this population.
I started smoking when I was maybe 15. My brother encouraged me to smoke, and I didn't really smoke for a couple years after that until I was until my lady friend was in college, and I started about late, like 21, and then I smoked. I just got hooked.
I started smoking when I was 10 years old, and we would steal them out of my grandfather's cupboard, you know. Me and my cousin would, you know. We'd snack a pack every now and then. He smoked a lot, and we grew up working in it too, you know. And now I really didn't get addicted to it until I was probably about 14. But by the time I was 14, I was smoking every day, and I did for years.
I got curious about it. I think I was 11 in the 6th grade. My parents both did it, and I guess I just thought it was cool, you know, not realizing the road down ahead, you know.
Tobacco use is widespread in our population. The national prevalence for people with, for example, schizophrenia is an 80% smoking rate, and that's pretty much what we see here.
Tobacco use is a very big part of people that struggle with different types of mental illnesses for lots of different reasons, one of which is I think that it's been a habit for a very long time. So typically they come to us having been smokers for years and years and years, especially those that really struggle with significant, severe, and persistent mental illness.
Well, we do see tobacco use as a problem. We see it as an issue that certainly has taken people's health, in some cases taken their lives.
I think when you have a mental illness, especially a serious mental illness, that's obviously where the focus has to be in terms of treatment. But what we're finding is that a lot of the people, as you suggest, that have a mental health disorder also have an addiction disorder, almost always including tobacco. It's really interesting as we look in Indiana at the opioid epidemic. One of the issues that might surprise some is that almost everybody that's addicted to an opioid is also addicted to tobacco. And the irony of all ironies is that the numbers in terms of death rate are much higher with tobacco.
Individuals are motivated to break their tobacco dependency. They simply need professional help.
When I had quit the last time for two years, it was between 2011 and 2013, I had quit drinking as well, and I had almost 2 years of sobriety again. And the night I started smoking again, I had went and bought alcohol.
I had hee-hawed around. I had tried the patches. I had tried cutting down, and for me, that didn't work. I can't halfway do something, because it's not a halfway addiction. It's a major addiction.
I want to quit before it kills me. It's already taken my breath. It's already taken my breath.
You know, tobacco is an addiction, and that's the key. That's very important to remember. It's not just a bad habit, but tobacco is an addiction. Nicotine is very addictive. It's as addictive as cocaine and heroin.
Their symptoms of their illness are very stressful. You know, schizophrenia has got a lot of negative symptoms associated with it. You know, people with depression, they struggle to get out of bed in the morning. And tobacco use can help alleviate some of those negative symptoms.
And we know from our research literature that smoking does have a satisfying or a so-called palliative effect for people. It doesn't last very long. So Unfortunately, that creates a chain that makes ordinary chain smoking look like child's play.
Our clients die at least 25 years younger than the general population. And a lot of that is caused by the effects of smoking, be it heart disease, lung disease, everything. It affects everything. It also affects their medications.
We know that the hydrocarbons in cigarette smoke rev up the enzymes in the liver that metabolize the antipsychotic medication. So they actually get a little bit of relief from the side effects of their antipsychotic medications. Unfortunately, that also decreases the effectiveness of their antipsychotic medications.
The things that we've been doing in the general population to help those individuals quit smoking hasn't worked with this population. So I think that's why we see a larger number still continuing to smoke, and we don't see a change in the smoking rates in this population like we do in the general population.
When I was in residency, I had a staff member tell me, there's a senior staff member say, you know what, schizophrenics smoke, that's the only way, that's the way of the world, nothing you can do about it. I think that is an old-fashioned way of thinking, and it is simply not true.
The people who run the programs are pretty smart people. They know this is a problem. They know the statistics. We've been talking about it a long time. So I kind of come from an issue of what would motivate them to really begin to think how they implement these programs that are client-centered versus regulatory-centered.
I think that to implement any type of tobacco protocols and be able to sustain that, it is a difficult thing, but it's important. There's so much help that's out there at the state, the local, even the federal level for tobacco cessation, and yet people aren't aware that there's a resource out there that can help them quit. And so by implementing and maintaining those at the local level, you can educate people and your consumers to be able to get that knowledge and take that first step to being able to live a healthier life.
In our time right now, we are charged with not just taking care of the mental health of a client, but also the physical health. And so our whole goal is to treat them as a whole person. And you can't do one without the other. And smoking and tobacco use really plays a huge part in that and really negates a lot of the potentials of what we can do to be effective in their care.
But I also think providers feel like it's not really their role, or maybe it's not their job, or maybe, and I think the other biggest barrier is that providers feel like their clients don't want to quit.
I think the staff felt that it would impact the clients negatively if they quit. And there's a lot of myths about that if folks stop smoking, their symptoms will get worse and, that it'll be harder to treat. And that's been proven that that's not true at all.
We know that people that do smoke and have a mental illness tend to have poorer outcomes and more hospitalizations and need more mental health treatment. However, if they do quit smoking, their outcomes improve quicker.
And I just think it's an education thing as much as anything, to educate people. And it's the same. They need support, they need education, and just to keep working on it.
Clinicians know how to help their clients. It's simple. Promote tobacco treatment, and clients will quit at a higher rate.
It seems like I've tried a whole bunch of times. I did manage about a month ago to quit for 5 days in a row. I just got determined, and I was wearing the nicotine patch, and I did it for 5 days straight, and I thought, wow, you were doing good there. And then the urges took a hold of me, and I went back to it. Wasn't a very good idea.
Like I said, the reason I'm doing this is not because I smoke for the fun of it. I smoke because I'm an addict. And there's no pretty way of saying I'm an addict. Even if you put lipstick on it, I'm still an addict. In most other ways, I was getting along with people. I was paying bills, doing all these things. But when it came to cigarettes, I just lost my sense.
That's how powerful nicotine is. In my opinion, with all the alcohol and things that I've done in my lifetime, the hardest thing I've ever laid down has been nicotine.
In the end, if I could beat what killed my dad, I will be so proud of myself. It's enough to make you want to cry.
Tobacco-free environments will help staff and clients. Smoke-free policies work.
I think it's really important as a leader in an organization to put the staff and their health in perspective. And what we said and what we believe in is that our staff should not have to go into facilities that are smoke infested.
I think that when staff smoke, it kind of normalizes it, and the clients see that, well, hey, I view you as well off or doing well in life, and you smoke, and I want to emulate that because I want to think that I'm doing well off in life, and so I'm going to smoke because it's a status. People can see that. If I'm well enough to smoke, then I must be doing okay elsewhere in my life.
Yes, I'm also concerned that there is a certain hypocrisy in staff people smoking, but are really working, full-time on consumers not smoking. Certainly we're aware as more and more of us become smoke-free and we don't smell like smoke ourselves even when we're not smoking, that it's really, really hard for people who are trying to quit or who have recently quit to detect that little suggestion on the rest of us.
I know that if you just state it in general terms, like how could we ever, or we could never get our group homes or our staff to be smoke-free, if you think of it in big terms, that seems overwhelming. But if you think about it in smaller terms and you do it one thing at a time, it's a huge morale booster for staff when you say, we no longer expect you to go into a facility that is smoke-filled. And while there are still some smokers in our staff that might be okay with doing that, even they get it that people that aren't smoking shouldn't have to be subjected to that.
Indiana needs to unite for change. This is about taking collective action to help clients live healthier. It's time for change.
Tobacco treatment in the mental health field, and certainly at the Midtown Mental Health Center, is one of our primary focuses. About 80% of our population is addicted to nicotine.
I think in my field, both at the psychiatry level, the social work level, nursing level, we still walk around thinking, smoking's a bad habit. No, it's an addiction. It's an addiction that has profound health consequences.
There's nothing more powerful than being able to say, I've been there. I know what that's like. I know what you're going through. Let's go through that together. Let me be your support.
And I think just raising awareness and keeping this in front of providers and helping them to understand that they are the experts. They have the knowledge, and their clients are wanting to quit and can quit with their help.
We hear it a lot, that the change has to include us. To be honest, we get tired of hearing that. There's only so much that a small group of people can do. But there's an element of absolute truth to that.
I think hitting it with total support from senior leadership is critical. Everybody has to be on board because you will have complaints. You will have people that don't want to do it. I think that you have to hit staff and clients as well. You can't do one without the other. I don't think this is a choice that we have to make anymore about whether we do this or we don't do this. I think it's our obligation. We can't let our clients continue to die from tobacco-related diseases and illnesses, and we know they are. It's irresponsible on our part, so we have really not a choice about doing this. I think you have to grab it and go for it.